you know that nearly 50% of people who suffer a heart attack show no signs or symptoms that doctors relate to heart disease, and they have normal cholesterol in a basic lipid panel? My dad was millimeters away from a heart attack when we discovered that he was at risk. My dad is actually here right now to share his heart disease journey from diagnosis to treatment, along with his new lead interventional cardiologist, Dr. Joseph Yang with the VA in San Francisco. Welcome, everyone. I think I want to start with my dad. Thanks for getting up early for this. Dad, you know, you went to your general practitioner complaining of chest pain that you likened to heartburn. And then we asked, well, could it actually not be heartburn? Maybe it could be signs of a heart attack, because your mom and dad, my grandma and grandpa, had heart disease. And she said what?
Well, Kim, she said, you have a normal or good cholesterol in the basic lipid panel, so you can't be at risk. Mm-hmm. We pushed for an EKG anyhow. We found an abnormality, trying to pronounce my words this morning, and after a nuclear stress test, confirmed narrowing in my arteries, which the doctor said the next steps was an angiogram.
Okay, and so, you know, what happened, you know, at that point? I mean, there was no discussion of approaches, no tools, no techniques. Prior to this angiogram, your first cardiologist wanted to just throw you on the table because of a cancellation the next day. You didn't even know the location of this narrowing in your coronary vessels or their treatment strategies. You didn't even know the doctor. Were you actually ready?
No, it scared the H out of me. Diagnosis is one thing, but waking up to the potential of having a half a dozen stents was scary, and especially done by a doctor I have never met before doing the procedure. So we requested a 256 slice CT scan to get the 3D modeling of the heart and have a productive discussion with the doctors about what needed to be addressed. Also, we were specific as to what atherectomy devices and stents we preferred. We ended up agreeing on only one area. The 95% blockage in the circumflex was critical, and to make lifestyle modifications and see how my body reacts to the stent, medication, and diet changes.
And you did really well. And then just 1 year later, you had another 256 slice CT scan, which showed actually a quick progression of plaque outside of those stents, including a 90% plus narrowing in your right coronary and a 70 to 80% long calcified narrowing in your LAD. But the cardiologist, your other cardiologist, the older one, said no treatment was needed. Why?
He just said I had no symptoms, which 40% of heart attack sufferers show no symptoms. Come back in 6 months for a nuclear stress test. So I went to the VA for a second opinion. That's where I was able to get referred to Dr. Joseph Yang, and he was very methodical in reviewing my data and in his approach. Mm-hmm. He reviewed the films and detailed his strategy. It just inspired confidence in me that he was the man for the job.
Yeah, and Dr. Yang, what surprised you about my dad's case? Kind of walk us through that two-pronged approach that you took, as well as what others could actually learn from it and use to facilitate a productive conversation with their own doctor.
Yeah, thanks, Kim, for having me. Hi, Bill. Good morning. Good morning, everybody else.
Good morning, doctor.
I'll say this. I think I'm lucky because, you know, it's easier to come in once you have all the information already in front of you, rather than meeting somebody for the first time and gathering all the information yourself. It's easy in hindsight to see what you think can be done. And so we had a lot of information when I saw Bill for the first time with my excellent nurse practitioner, Sarah Goodman, who helps take care of Bill with me. So you know, I think Bill is a very active guy at baseline and very functional. So in my experience, patients like that a lot of times can look quote unquote asymptomatic because they've just been so functional at baseline, and they did so much activity, and they don't even realize themselves that they're slowing down because of of coronary disease. And so we saw the CT scan. We were able to look at that and review it, and then we said that the next step is probably to repeat the angiogram. And we didn't know what it was going to look like either, change, but we discussed that these are the things that we'll look for, and then we'll make a decision at the time based on what we think we're going to find. I'll say also, I think I'm lucky that as an interventionalist, I get to see a lot of my patients before doing a procedure on them. So Bill and I and Kim, we had spoken at length with Sarah, but I realized that not all. I have many patients that I take care of as well that are referred from my colleagues that I may be meeting for the first time on the day of the procedure, but we try to talk and go over everything that we're thinking about and why they were referred before the procedure as well.
And so you want to show us a little bit of the procedure? I'm not sure if you have both of the procedures, but we'd love to see exactly what you did during the, the angiograms that others could learn from, to see what actually happens and what are the possibilities and why you make the decisions you do while the patient is on the table.
These are my disclosures. I don't have any financial conflicts. I do have to just say that the opinions here are my own because I do work for the government and not from the U.S. government itself. And that Bill has agreed to show it. So you heard Bill's story. I first met Bill after he had already been stented in the left circumflex, which we'll look at, and then he had a repeat CAT scan done, including which Dr. Gupta mentioned. He had CT FFR done, which is fractional flow reserve. It tries to mimic a functional study based on the imaging to see whether or not the imaging suggests that the blood flow is limited by a blockage. And so we had already had this, and we had a long discussion in clinic with, as I mentioned, with my nurse practitioner and myself about what our plans were. And the first thing to do was to take another look. So as Dr. Gupta had shown you, we start with cardiac catheterization. We did this from the radial approach to the wrist artery. And this is a catheter here in the right coronary artery, as you can see. And the arrows show this kind of severe blockage in the mid portion of the right coronary. We then flipped around to the other side and used a different catheter to engage the left coronary, of which there is the left main that branches in most people into the left anterior descending and the left circumflex. Bill had a stent placed in the left circumflex before, and the CT FFR suggested that there was flow limiting stenosis in the left anterior descending. And because there's two arteries on this side, we take multiple views in general. And the arrows here point to the kind of 70 to 80% stenosis in the LAD that was positive by the FFR analysis. And then here, these yellow arrows point to the circumflex stent that was placed elsewhere, and it looks awesome, just honestly. So Bill had a great result there. So the next steps that we had on the table, and this is what happens sometimes when we do the diagnostic test, and then we go into, we're already in the wrist artery with catheters, the patient's already sedated, and we have a discussion about what the next plans are, how to tackle each artery, what to do next, in discussion with my team at the time. And with Bill was that I thought angiographically the right coronary artery was the most severe. It was very calcified, so I think it was probably a little bit, once you have a lot of calcium in your arteries, the CAT scan, the x-rays can't penetrate the calcium as well. So CT angiography sometimes can be difficult. But I thought that the right coronary was the most severe. And I also thought that the left anterior descending anatomy could potentially be complex. I was not planning a complex approach for it, but kind of you always have to be ready. So based on that decision, our thought was, we've spent some time already to take the pictures. We spent some contrast dye and x-ray exposure to Bill at this time already. So we should do probably one artery first, fix that, see how he does, and then discuss down the road whether or not we should come back and do the other one. And because the right coronary is more severe, I thought that the best thing to do was to fix that one first. So this is just us with guiding catheters. This is a catheter in the artery from the wrist. This is a wire and then a balloon here doing angioplasty first. This is deployment of the stent. And this is the after images. Remember that the blockage was here, and the artery looks great. It's completely open now. It's nice and smooth, and we got a very good result. Bill actually tolerated the procedure really well, and we were able to do same-day discharge, such that Kim came and picked him up a few hours after the procedure, and he went home and was doing great. So we met in clinic and discussed a few weeks after that about whether or not we should proceed with the LAD. It's probably the most important artery in the heart. We had a functional study based on the CT that suggested it was positive, suggesting it was flow limiting. So we discussed what to do. I'll go back and show you the pictures in a little bit, but it was pretty calcified based on the CT scan that we had. So I thought best probably to debulk the plaque a little bit with atherectomy, which we commonly do here at the VA hospital here. I also thought that there's a side branch coming off of it that I wasn't planning to stent, but certainly stenting across it can shift the plaque into that side branch. So you have to be ready to work on that if the issues arise. And then I was planning to do intravascular imaging because the artery is very big and to make sure that we got a good result. So the first thing we did was re-looked at our handiwork from the first time before, and the stents still look really good as you expect a few weeks later. Came over here, and again, this is now us getting ready to work. You can see the left anterior ascending it's quite big here, and then it gets very narrowed here. You can't see the calcium shadow outline, but it's pretty heavily calcified. This is a different view where the left anterior descending comes down the front of the page here. And then you can see there's a severe narrowing here and here. So this is the actual stenting procedure, some still images from it. You can see that this actually is the atherectomy crown. We used something called orbital atherectomy, which is a spinning crown, and it rotates and they say kind of jump ropes and makes a bigger loop through the artery in a safe way because it shaves down the calcium. And then, as I mentioned, there's a wire in the main artery, the left anterior descending, and a wire in the side branch to protect it. This is us ballooning. This is the first stent that was placed in the left anterior descending. And given the amount of plaque that there was, it actually took a second stent because the longest stent we have is 38 millimeters. And here is the second stent. This is us doing intravascular ultrasound. This is an ultrasound catheter to look at the artery from the inside. And then this is the final images. The artery is very beautiful, nice and smooth coming down the front. And here you can see it's much larger and wide open. And those are the results. And just give you comparisons. This is the pre-right coronary artery, very narrowed here, and afterwards nice and smooth. And here is the pre and post again of the left anterior ascending, where you see this very severe narrowing. It's nice and open here. The vessel itself is a little bit widened here, and it kind of flutes down, but it's nice and smooth. And this is again the pre and post. So the next steps, Bill and Kim and Sarah and I, we've met a couple of times now to talk about what the next steps are. Stenting is great. It can decrease previous symptoms a lot. Potentially it can decrease the risk of heart attacks in lesions that are positive by functional study. But no matter what, risk factor modification with Bill's great diet, his exercise, and medicines for coronary disease are the key next steps. And that's how we've agreed to proceed. And I'm hopeful that Bill will do really, really well with kind of a very, very, overall, very comprehensive medical management with us and with his other doctors. And thanks. And just to remind you that San Francisco VA has like the best view of any hospital in the country.
I love that. Yes, it does. And doctor, diet and supplementation, it's really, really important, as well as exercise, but it can only go so far in overcoming, the 40, 50, 60, 70, even 80 years of momentum that you have in diet and all that stuff. And so sometimes that plaque just continues to build for a while. And that's why medical therapy is also important, coupled with the diet, the supplements, etc. But you noticed a difference because of his diet and his supplements and such in the stents themselves. So while the plaque was building around, the stents remained clear because his blood work improved, correct?
I think it's potentially possible. I agree with everything you said. The other thing that you can't really run away from is your genes. So for Bill, with parents that both have coronary disease, that probably is a predisposing risk factor that no matter how good your blood work looks is an independent risk factor and something that we can't control. I think a lot of those things are how I think the biggest point for me is, despite all the plaque buildup and all those things, Bill's never really had a heart attack. He had kind of an unstable angina presentation originally at the first hospital he went to. But he's never actually had a heart attack. The heart pumping function is normal. So I think that all those things are very attributable to him at his age, which I won't reveal, helping him make it that far without having a heart attack. And it's our job working together to, to do our best to prevent him from having a heart attack.
Yes, thank you so much, Dr. Yang. Interventions in medical therapy can only go so far. Exercise, we mentioned diet and supplements, right? But exercise is also really important. Dad, how much do you exercise every single day, 5 days a week?
Well, 5 days a week, I'm up at 4:45 and meet my neighbor 2 houses up the street, and we do 4 to 5 miles walking, sub 20-minute mile doing the hills up off Las Colinas. Then I come back, and that takes whatever, and come back and do an upper and lower body workout, which includes weights, stretch, balance, 30 minutes on the elliptical. And after that, I come into my office and follow the heartmath.org program, heart to brain and energy meditations. Then I have my morning prayer, and then I do 6 sessions of Wim Hof's breathing exercises of 40 breaths on each exercise. And on the 6th set, as I do my last exhale and don't breathe, I drop down and do 50 push-ups. So
No, wait a minute.
Morning.
How old are you, Dad? Dr. Yang
Gonna
wouldn't
be
say it. I
8
won't
and
say
10
it.
months.
Yeah, exactly. Oh my goodness. How many people do you know that does that? I'm sure Dr. Yang doesn't have that many patients then.
I don't do that myself. So Bill, you're making us look bad.